All right, thank you, and good morning. So we see protrusio in a wide variety of conditions, particularly in the rheumatoid patient or in patients with a history of JRA, but it's also common in patients with osteoporosis, osteomalacia, Marfan syndrome, as well as occasionally in the osteoarthritic patient that just went on with some other comorbid conditions. Commonly, I would see it in my practice in the acetabular fracture, as well as patients that have had a previous hip replacement and went on to loosen and erode their bone through osteolysis or other means. So the goal in the treatment of protrusio is obviously to appropriately position your acetabular reconstruction, but also importantly to resolve any bone deficiencies, achieve well-fixed components that are stable, and also obviously restore the hip biomechanics and reconstitute leg length and offset. In the case of protrusio secondary to the revision setting, component removal in the absence of significant bone loss is obviously important because tearing out a cup that has some native bone is going to make the problem much worse. So for these patients, I will position them like a primary. I love intraoperative fluoroscopy because I know exactly where I am. It's important to do an appropriate femoral release because in the setting of a well-fixed stem, getting access to the acetabulum is somewhat difficult and can be challenging. Removing the cup without significant bone loss, and then reaming and bone grafting to reconstitute the medial acetabulum that's deficient. I use screws in a majority of these patients because of the significant bone loss, and obviously there's usually some good bone that you can get a nice size screw into. I move the stem out of the way and make a pocket to move it superiorly, posteriorly, and then that gives us excellent exposure to the acetabulum. So in this case, this is a patient that had a previous revision and again did not get good fixation and obviously lost a lot of her medial bone that was that the cup eroded into. So reconstituting that medial acetabulum also gives us the ability to lateralize slightly to recreate a more natural hip center, and then obviously bone graft and screws. In the case where there's a previous fracture and like John was talking about in the case of dysplasia, you can use the native femoral head as bone graft. So I simply made an in situ neck cut and then just medialized and impacted all that native bones to reconstitute the bone loss that was created because of the fracture. Just to end with a couple cases, this was a patient that had a total hip in the 80s and had a series of revisions. So basically she had, what you're looking at is basically all cement. So she had a cemented cup. So she basically had essentially a shear wall with significant bone loss. And in her case, removing that, the polyethylene cup as well as all the cement left me with basically really very little bone to deal with. You can puncture the medial wall. Don't be afraid of doing that. In this case, I was able to move that the stem, which was well fixed, in a posterior superior pocket, and then medialize, reconstituting. I bone grafted, and then I have a low threshold to use a cage in these cases because the bone is so deficient. And having fluoroscopy, you know exactly where the cage is going. You can appropriately position your cup and recreate a more anatomic hip center and obviously restore hip biomechanics. So again, another polyethylene cup with significant bone loss, cemented in, and that cement all eroded. I punctured the medial wall slightly just to get good exposure and appropriate fixation. So my take-home message is basically be patient with yourself. In the setting of a revision, go very slow and assess the bone loss, particularly in the acetabulum, and don't be afraid to bone graft significantly because that will give you the ability to reconstitute the native acetabulum. It is a relatively straightforward approach in the setting of revision in a well-fixed stem. A contrast to the posterior approach, you can move that femur out of the way, but most importantly, understanding those femoral releases will give you access to the acetabulum and easy exposure.